Hello, this is Dr. Paul Cottrell and student Dr. Paul Cottrell, and today I'm going to be talking about long COVID. So there's a few documents that I've been putting in the links in the thumbnail videos that I've been doing. Please read those. It goes into much more in-depth analysis of what long COVID is and some of the funding that is happening with the NIH. For example, the NIH said in 2021, I believe it was, that they were going to allot about $1 billion in long COVID research and screening. So please read that article, but there's a set of 3 articles. 2 of them are in the thumbnails, in 2 thumbnail videos. You have links to two of them. I'll put another link to an article that you can look at in this video. This video is going to be with the Patreon subscribers. They've been supportive and over 2 years, and I figured that I would give something that is very specific just to them. But I appreciate your support, and please subscribe to all my channels, the 3 channels on YouTube, Brighteon, Bitchute, and Rumble. The ones that are subscribed to Patreon, thank you very much, and it helps to support the research because I am demonetized and heavily censored on YouTube. So, what I want to do is talk about long COVID and its manifestations. So Peak Prosperity did a video. I don't have time to watch other people's bullshits because I am way too freaking busy. So, but the title said something like there's not cardiac issues doing long COVID. That's total bullshit. There are cardiac issues in long COVID. And I'll tell you 2 of them right now. And it's not the only ones, but myocarditis and a disruption in the feedback system between the sympathetic and parasympathetic nervous system controlling the heartbeat. We know this for a fact because we had a nurse on my channel talking about her experience with long COVID and how she had tachycardia. All right, so basically what it is that your body will be in a certain beat rhythm and you have a parasympathetic nervous system to slow it down. Well, if the vagus nerve, which we think is being affected by COVID, ends up being disrupted, then the ability to slow down the heart is diminished. So the parasympathetic pathway is compromised. So unless I misunderstood what Peak was saying, in his title, he doesn't know what the fuck he's talking about. So, what I want to do is break long COVID down into a few categories. So we're going to long COVID. Okay, and it's going to be broken down in a few categories. The first category is the central nervous system. Now, it can also have peripheral nervous system disorders too, very similar to GBS. But where I'm citing this from, it specifically focused on the central nervous system. So you have the central nervous system, you have cardiovascular, you have hematologic, you have what they call post-intensive care syndrome. All right, and then psychosocial. Pulmonary. Stuff it. And then renal. I'll go into detail in each one of these. Gastrointestinal. Okay. Now, as you remember, for example, I just earlier in the video, in this video, I talked about how the nervous system. So you have a peripheral nervous system, a central nervous system, and autonomic nervous system, right? So I've already talked about how the vagus nerve could be disrupted, disrupted by SARS-CoV-2 and lead to cardiac manifestations, cardiac issues that are part of this whole long COVID. There's cardiovascular, there's hematological, post-intensive care syndrome, psychosocial, pulmonary, renal, and gastrointestinal. So what I'm going to do is I'm going to go for each one of these categories, I'm going to go into detail. Okay. So let's start with the central nervous system. So with the central nervous system, we can have strokes, polyneuropathy, encephalitis, altered consciousness, headaches, and hyposomnia. I think the ones that we hear a lot of are people not being able to sleep, people that are having the headaches, individuals having fluid, kind of a buildup of fluid in the brain, issues with their nervous system. Now, what I would, what is interesting is this polyneuropathy. This polyneuropathy. This can be this could be PNS and CNS, not just CNS. But the authors of this paper could have been just kind of bucketing everything under the CNS. Okay, so now we also heard about these microstrokes. Now, what is interesting with long COVID, they didn't mention here that I would add, I'd put an add in here, is this amyloidosis. It's amyloidosis. And what this is that this amyloidosis is a buildup of plaque. This is like your proteins, and your proteins have to fold a certain way, right? But if the protein ends up being disrupted and folded in a wrong way, it may cause pathology. And we know that SARS-CoV-2 disrupts what is called the lysosome. So in the cell, nucleus, the cell, you have things, vesicles in the cell. This is the nucleus, this is the lysosome. The lysosome will come in and kind of clear up misfolded protein, degrade it, recycle materials. So it'll go in and eat up that misprotein. Well, what happens is that with SARS-CoV-2 infection, the lysosome is hijacked. It's kind of disrupted. And when it's disrupted, you'll start to have a buildup of these misfolded plaques and eventually amyloidosis. Okay, so now let's talk about cardiovascular. Okay, now cardiovascular. So we have MI, so heart attacks. You have what we would call cardiovascular disease, which is cardiovascular disease is the main category, and MI is kind of underneath cardiovascular disease. So cardiovascular disease, you can have myocardial infarction, right? You can have cardiomyopathy. Okay, now this is where we're talking about the myocarditis, the endocarditis, well, the firing is arrhythmias. So you also have arrhythmia issues. Now, here is with this arrhythmia issue, this is where the CNS, sometimes when you're looking at the manifestations of disease, it's like a Venn diagram, and there's like an intersection. So this is let's say the cardiovascular part of long COVID, and let's say this is the nervous system, the NS, right? And sometimes there's a overlap, and in that overlap may be, in this case, we'll call it arrhythmias, right? Arrhythmias are where your heart isn't pumping correctly. It's the beat is you may have atrial fibrillation or ventricular fibrillation or ectopic beat. Something is not. It's not a regular beat, and there's something that changes. Okay, so that's the arrhythmia. But what we said in the CNS is that it's section that nerves can be affected, such as the vagus nerve, and the feedback for the parasympathetic slowing down of the heart, right? So here is my point, is that vagus nerve being infected, or that vagus nerve being compromised, may be transitory, may be permanent, but being compromised in such a way where you have tachycardia, you will start having, issues with beats of your heart. Okay, so you may be normal beat, normal rhythm, but tachycardic, or normal rhythm, bradycardic. Arrhythmias are differences in that normal beat. Okay, but the point I'm making here is that you can have cardiovascular and nervous system manifestations that have that lead to some sort of manifestation, some sort of clinical manifestation. Okay, so that's cardiovascular. Now, what we want to do here is hematological. Okay, and that is where we start seeing the blood clotting. Okay, so heme meaning blood, right? So hematological. So this is like the blood stuff that we're dealing with. Okay, so we've talked about this, overcoagulation or blood clotting. So coagula, I'll tell you, my tongue just doesn't want to move, right? Coagulopathies. So this basically means that changes in your coagulation, okay? So this is an increase in coagulation. Lymphopenia. So this is a decrease in lymphocytes. Thrombocytopenia. So this is what we've talked about. There's different types of thrombocytopenia, and even Dr. Fleming, I personally think it was one of the first that were really talking in detail about thrombocytopenia two years ago or a year and a half ago. So thrombocytopenia, and there's lots of types. There's ITP, which is kind of like an infection-related thrombocytopenia. There's an immune type of. There's also an ITP that's immune related. There's different categories of thrombocytopenia, and one of those. Cytopenia. Okay. All right, and then there is the disseminated intravascular coagulation, DIC. So this is disseminated intravascular coagulation. Now that is a thrombocytopenia, but it is systemic, and this could be deadly. So there was lots of cases that we've heard about this happening with COVID, the thrombocytopenia, the coagulopathy. But this is longer term, all right? These, you can have thrombocytopenia that's acute, but when we're talking about COVID, we're talking about chronic. This is a chronic disorder, not an acute disorder. When most of the cases of SARS-CoV-2 is an acute case, right? But different researchers put the delineation between acute and chronic at different points, but I'm using about anywhere from 3 to 8 weeks where you still are having issues with your COVID infection, your SARS-CoV-2 infection. You're still showing signs of COVID after that 3 or 8 weeks of post-hospitalization when you're discharged. Now, it doesn't mean that you can't get long COVID if you're not hospitalized. You can get long COVID even if you're not hospitalized. But a lot of these cases that are coming up in the data, it's hospital related. Okay, so DIC is kind of a more severe form of thrombocytopenia. So what basically thrombocytopenia means is that there's a reduction of your platelets. So your platelets are going down. The reason being is they're clotting. Okay. So when it clots, it's collecting those platelets, right? So your platelets are going down. Well, DIC, disseminated, meaning kind of like disseminated in your body, so it's more systemic. Intravascular, so it's in the vascular system. Coagulation, so it's coagulating, so it's creating clots. And what happens is that this ends up dropping your platelet level really, really low, right? And through all these little microclots, and then eventually you can die from this, actually. Some women end up getting DIC when they're pregnant, if they have an infection or some issue with their pregnancy. So and also if you have genetic disorders where you're missing an enzyme, I think it's ADAM. I think if I remember right, I think there's an enzyme that's called ADAM13, I think it is. Or is it ADAM 13? No, it was a TV show in the 70s. ADAM something, maybe it's 7. It's ADAM something, I forgot what it is. So, and this enzyme helps to trim part of the clot area to prevent it from over clotting. If you have this missing enzyme, then it will clot quicker. Okay, I had to look up exactly the mechanism. I shouldn't have, I forgot it. All right, so now post-intensive care syndrome. Okay. Delirium. Mental health impairment. Cognitive impairment. And muscle wasting. And weakness. Now, obviously, because you have been in intensive care, you've been been in bed, you've lost muscle mass. Some people that are older, because they're having pulmonary problems because of long COVID, they can't exercise and gain muscle, and so it's a kind of downward spiral. You see a lot of this with geriatrics. Now, the question is, why is the delirium, the cognitive impairment, and the mental impairment happening? In clinic, we were doing a case that I was talking about an elderly patient that was having, that if they're dehydrated or their electrolytes are imbalanced, that they can go into delirium, or if their medication is not adjusted, right? But they get dehydrated or whatever, they can go into delirium state. And especially if they're older and they're put into an intensive care unit or in the hospital, it could exacerbate the issue. That might be the problem, but this is after they get out. Normally they mean revert back, but what's interesting is that they maintain delirium after they get discharged. Well, a lot of this we would see in care units. So this might be due to, increased dehydration. So chronic dehydration may be electrolyte imbalance. So like your sodium, your potassium imbalance. They might be what we call hyponatremic or hypokalemic. And then obviously, because there is some sort of delirium or some sort of change in, mental state, they're not thinking as well. So this might be back to the Venn diagram. So you're what we would call post-intensive care syndrome, and let's say renal could have some sort of intersection that's causing this. Okay, next, the psychosocial manifestations. Okay, psychosocial. Okay, what do we have? We have anxiety. Depression. PTSD. Sleep disturbances. Chronic fatigue. And panic disorder. I think there's a lot of research that needs to be done to understand this dynamic, why this is happening. Now, the depression, it probably is because of loss of maybe employment. Decrease in employment, maybe, issues with money. Anxiety could also be, related to employment and money. The anxiety could also be due to shortness of breath. The PTSD could be that they had a very traumatic experience with with COVID-19. Sleeping disturbances. This is a very common theme, and even nurse had it. Where you had sleeping problems, not being able to get into REM, so decreased REM sleep. Now, is that because of the amyloidosis? Maybe. Chronic fatigue. This could be, muscle weakness also. Panic disorder. This could be, tied to the anxiety. Maybe they're afraid of getting COVID again because it was so disruptive in their life, so traumatic. So that's a real thing, and that can cause physical manifestations. It's not just like psychosomatic. Okay, now pulmonary. Okay, lower exercise capacity. So exercise is going down, right? Decrease exercise. Impaired diffusing capacity. I want to go into detail about this. I did a video on this. And I think when you read my paper that I'm going to be publishing to the public soon here, I'll tell you a little bit more about it. Impaired. And then fibrotic. Yeah, this is kind of tied to it. Fibrotic. I want to go into a little bit more detail on this part. Fibrotic intestinal, or no, fibrotic interstitial. Lung disease. Okay, I'll go into detail on this. Okay. It seems as though, for me, that from long COVID really focused on the pulmonary cardiac, but that all those other things that are important, renal, psychosocial, hematological, obviously, because of the blood clotting and the CNS issues. Okay, but pulmonary and cardiac I've been really focused on. I want to go into a little bit more detail here. So why are there pulmonary manifestations with long COVID? Well, exercise tolerance is decreased. Why? Because you can't get enough oxygen in while you're exercising. This is part of the reason why some of these long COVID patients, instead of like going on a bike or running on a treadmill, the best thing to do is probably just to walk. But even some of them cannot do that, even low intensity exercising. So it's an issue. So exercising capacity is diminished. Now, what is really going on in lungs? Okay, you got the trachea, the trachea, the bronchial tubes, right? You got your lung, right? The two lungs. All right. But in here, you have something called a VQ. So this is ventilation and perfusion. So perfusion is the blood flow, and ventilation is the exchange of the gases, carbon dioxide and oxygen. Right? So when this gets disrupted, your lungs can't work well. Well, a lot of these patients, when they did CT of breathing in, I think it's xenon gas, charged xenon gas, and then did a CT of that, they noticed, compared to normal lungs, non-COVID, versus long COVID lungs, that the perfusion of gas, so this ratio, is disrupted, and that it's not perfusing. So I'm going to draw the normal lung. So this is normal lung, and then let's say this is COVID. Okay, just to explain what's going on here. Okay, so the normal lung will diffuse oxygen relatively uniform. Okay, and be able to get rid of the carbon dioxide. In COVID lung, what will will happen is that you will have pockets where it works okay, but not everywhere. All right. And this is showing a sign of pulmonary disease, probably permanent. All right. Now, I talked about that there are probably going to have the early on, this is what, in 2020. I said that there's going to be a COPD, so like an emphysema kind of thing. This is what is called obstructive pulmonary disease, and then a restrictive. Okay, now what's the difference? The reason why I was saying in some patients you may be seeing COPD is because your alveolar sacs are getting blown apart. And that what's going to happen is that you'll have more, they won't remodel, and you'll just have a larger, normally how the alveoli work is like there's a little bubble, another bubble, and then a path, like a pathway, right? And then there's another little bubble, right? And this is where your type 1, type 2 pneumocytes are. Well, in COVID, what was happening is the septum, these lines here are the septum. They would get destroyed and they wouldn't remodel. So you end up having more space in that air sac. That's COPD. Okay, so you're going to have some cases where you're going to have COPD. But what is interesting is that when they did this Xenon study, it was showing it's more like pulmonary fibrosis, and that's restrictive. Now, what's happening with pulmonary fibrosis is this. And I'm going to draw the ear sac zoomed in. So you have these, normally you have these type 1 pneumocytes. Okay. And this is like a ball. But I'm just cutting the section through it. Okay. And then you have some epithelial cell, okay? And then you have these type 2. So these are type 1. And once in a while, you'll have a type 2 cell. The type 2 cells is what COVID was targeting. The type 2 cells are your stem cells for this, okay? So COVID was blocked, was disrupting the remodeling capability. Okay, so it was knocking that out. There was infection, that this starts to break down. Macrophages come in, start releasing their granules that are eating away the elastin, that elastin or elastase. But it's releasing a chemical and it's breaking up the infection, but it's also breaking up and causing damage to type 1s and type 2s. So what happens is that in a more severe infection, this thing starts to leak and more interstitial fluid starts to flow in, and this starts to fill up with debris, fluid and debris. This is happening in all those sacs around in that area. Right? So this becomes a big problem when you're looking at all these little different things that are feeding into each other, right? And they start to leak. And once they start to leak, and more macrophages start to go in, more debris is starting to build up. There's blood that starts, because there's blood There's blood vessels that are all around these alveolar sacs, blood's flowing in. So there's lots of debris, blood, fluid, proteins, right? And if there's enough damage, what happens is that the space in between the alveoli, this space here is the interstitium. This interstitium will start to deposit collagen, and collagen is going to start to harden the area and try to circle this out. Okay, and this will start to become stiffer. So this is the restrictive. It's not as compliant. So because it's strict, it's the interstitium is now having fibrosis. It's building fibrosis. This area is now getting stiffer. And because it's stiffer and it doesn't have as many blood vessels, as functioning blood vessels, or the ability for the pneumocytes to function properly and diffuse gases, you start having diffusion problems. You start having exercise, intolerance, and this is what is called the impaired diffusion capacity. That is the restrictive. There's two types of impaired diffusion capacity, because even with COPD or emphysema, because you don't have as many cells, even though space is larger, you don't have as many cells to allow for diffusion of gases. So this can be COPD or pulmonary restrictive disease. Okay. Now this fibrotic interstitial lung disease, this is the restrictive that I'm talking about. And this causes that fibrosis, and it doesn't allow for that diffusion to take place. So I think a lot of COVID patients you're going to start seeing some that have the COPD. You're going to see a lot of them that are looking like they have some sort of pulmonary fibrosis. Similar, but not exact, but similar to cystic fibrosis. But it's different. Cystic fibrosis is different. Okay, now let's talk about the renal system. Okay, now for the renal system, the renal manifestations, you have acute kidney injury, you have hematuria, that's blood in the urine, and you have proteinuria, and that's protein in the urine. And you have nephrins in your kidney, right? So you have your kidney, and I didn't draw my kidney. Okay, and you have these nephrin you have a cortical and a medulla, right? And what that is that you have a glomerulus, and you have tubes that help with urination. And what happens is that blood is coming into the glomerulus and filtering blood and collecting urine. And you have a proximal tube and then a descending loop of Henle, ascending loop of Henle, then a distal convoluted tube, and then a distal collecting duct, and then the collecting tube, and then the collecting duct. And then urine will accumulate and then go into the pelvic area of the kidney, and then end up secreting out through the ureter. Okay, so this is the ureter. Okay, now, this is how we concentrate urine and filter out. Now, hematuria is basically blood ends up being in the urine. So blood end up getting in here. Now, what can also happen is that through AKI, acute kidney injury, you can have sloughing off of different parts of this tube, the cells in here, and causing tubular necrosis. And so you have sloughing off of the tubes here, and you might see what is called CAS. So with this issue, so there's something called nephrotic and nephritic. Nephritic is more blood related, and nephrotic is more protein related in terms of what's in the blood. Now, when you have acute kidney injury, there's a lot of things that can happen, and this is again a Venn diagram. You can have the renal system going down, and you can have cardiovascular. Now, if there's acute kidney injury and this is being disrupted, then your RAS system, what is called a RAS, the RAS system, renin, angiotensin, right, aldosterone system, it's RAAS. The RAS system, that gets disrupted and you can't control your blood pressure. So here is another one of those intersection points. And I'll bring this whole intersection point thing to the forefront on long COVID. Right, so let's do the last manifestation, which is gastrointestinal, before I summarize. Okay, so we have abdominal pain, right? We have GI bleeding, so gastrointestinal bleeding. And with DIC, remember I said disseminated intravascular coagulation. Well, when you're using up your platelets, you end up having hemorrhages. So this also explains why with COVID patients, why they were getting blood clots and hemorrhaging. Vomiting, nausea, diarrhea. So here, with long COVID, here's another intersection point where you have GI causing disruption in fluids because you have diarrhea. So you're bringing down your bicarb. When you're bringing down your bicarb, you're ending up having metabolic acidosis. On top of that, your nutrients and electrolytes are being expelled, which also leads to cardiovascular problems. So these intersections of understanding of these different manifestations is really important, is my point here. Okay. And then hepatitis. Okay, hepatitis is starting to become an increase. Now, what probably is happening is there's a disruption with your immune system, and you are now getting more, maybe infections or a flare-up of HBV or maybe HCV or maybe even HAV, right? But hepatitis ends up becoming a problem. But it doesn't mean that hepatitis is viral. This thing could be viral. This also could be, metabolic. Okay. Then pancreatitis. Now with pancreatitis, I think what's happening here is that you can have attack of the pancreas. So it could be immune, like an immune attack. It could be nervous system related, where it's not signaling, or it's signaling too much to secrete certain types of enzymes. So it's increasing the enzyme. And then it's causing digestion of the actual pancreas. Also, if you're having, another complication is if you're having, so here's your esophagus, here's your stomach, right? And here's your duodenum, right? Your pancreas is back here. And you have a vascular system. Here's your aorta. It's kind of like coming down here, right? All right. Now, your vascular system is branching off and it's feeding the stomach, right? And I think there's an artery behind. There's a gastrointestinal, gastro-duodenal artery, I think it's behind here. But the point I'm making here is that you have these blood vessels that are on and behind the stomach. Well, what happens is that sometimes these can leak and start I'm sorry, not blood vessels, ulcers in the stomach. And those ulcers in the stomach can leak to the acid, that hydrochloric acid can leak onto the pancreas and end up causing. So this might be related to some sort of gastritis, or ulcers. But if you have some sort of leaky issue with your blood, it might be causing infection and then leading to some sort of pancreatitis too. Okay, but I think the leaky blood is less of an issue in around the stomach. Okay, so that is covering all the different manifestations. What did we cover again? We covered the central nervous system. We covered the cardiovascular. We covered the hematological, the post-intensive care syndrome, the social, the psychosocial, the pulmonary, the renal, and the gastrointestinal. And now what I want to do is provide kind of a so this is CNS. This is, I'll try to draw this. It's not going to be easy. CB, CSB, or not CSB, it's cardiovascular system, CVS, cardiovascular system. Hematological. hopefully you'll get what I'm doing here. Post-intensive care syndrome. Psychosocial. Pulmonary. Renal. And gastrointestinal. The point I'm making is that in the Venn diagram, patients, COVID patients, are going to have complexity, more complexity when there's this overlap of these different systems, right? And so it is important for physicians, primary care physicians, and also specialists in these different fields to be doing a monitoring and screening for patients and watching for this type of complexity. Because if it's just one issue, let's say pulmonic, then let's say this is the entropy of the system over time. If it's just one system, they're normal, entropy meaning state of disorganization, right? So they're normal, then they get COVID, right? And then they don't go back to normal, they stay kind of like at this high point with long COVID, right? But they're managed, but that's pulmonic. Now let's say we have a cardiovascular issue too. Let's say some sort of thrombocytopenia. Well, they were normal, then they get COVID, right? Right? And they were starting to have some sort of thrombosis. And then they come back and then they don't have but you have to put them on anticoagulants for a long time. All right? So they never went back to steady state. So there's the pulmonic by itself and the cardiovascular by itself. But when you put them together, there's a synergistic problem that is happening. And with the poor perfusion of the gases, or the poor diffusion of the gases in the lung, and the potential for coagulation or pulmonary embolism, this patient is more critical to monitor. And the entropy graph is now more like this, where it's at a much higher state. So this is, let's say, A, this is B, right? Well, this is A plus B, or it may be synergistic and be more than the sum. So this may actually be greater than A plus B, right? This might be even greater than A plus B. But the point here is that we need systems in the clinic and tools and treatment plans that are focused on this, not just one issue. And a lot of times when it comes to these more advanced diseases, you're going to a lot of different specialists, and they're gonna miss the ball because they're focused on their individual entropy curve. And they're not gonna be treating the synergistic. So how do we solve this problem? So I wrote a paper for my clinic. It's a course paper that I had to write for a requirement for clinic for our semester that talks about this. I put not that much effort in it. It's an essay, so it's not like a dissertation or anything, but there are 3 articles that I cited that are important for you to read to understand what long COVID is. But the point that I was making in the essay, which I will release on SSRN, and you can read the essay, but the essay is basically talking about what the manifestations of long COVID is. I also go into a little bit more granularity between the PNS and CNS, and the need for primary care physicians to have cardiac and pulmonary screening tools to be able to assess this. Because your primary care physician or your family, let's say your internal medicine doctor, right? Or your family practice doctor is the frontline doctor to manage long COVID. Not your cardiologist, not your pulmonologist, or your nephrologist, because they're going to be focused on their individual entropy curves. It has to be managed by the primary care physician. Now, that doesn't mean that in certain cases, they may be still being referred to a specialist for specific needs, especially, let's say, for example, the acute kidney disease or injury. The acute kidney injury ends up being chronic and causes kidney failure. All right, obviously you're going to have a specialist for that. But the thing is that having the primary care physician focusing on these things until waiting for it to pop up. So if they know they were a COVID patient, they put them on a screening program to see if these different things start to pop up. If they know they've had long COVID, obviously you keep on monitoring to see if they're improving or getting worse, and then treat accordingly. But I think that what needs to happen is that better cardiovascular technologies at the primary care physician level are going to have to be implemented to be able to screen and treat long COVID. And as it advances, the patient's disease advances, long COVID, then other specialties will need to be coming in. For example, the heart disease may be so severe you end up needing some sort of bypass or some sort of artificial pump or something like that. If the pulmonary fibrosis is very severe, you may need a lung transplant, right? So your primary care physician isn't going to do a lung transplant. It's going to be your transplantation surgeon, and also followed with your pulmonologist. But the point I'm making is that the need to be able to screen, the power of using like Doppler technology and cardiovascular advances in pulmonary function tests, advances in this xenon diffusion screening that I believe it was Cambridge that was doing the research in the UK. If I remember, because the article that I was referencing was coming from the BBC, so I think it was from Cambridge. But the point I'm making is that building systems, designing ways to screen for these types of patients, because this is a very chaotic thing. And as you add more and more manifestations to the entropy curve, it gets chaotic and it becomes runaway. So I think that was the main point of this video. And I think it is an important point because not a lot of people are talking about. A lot of people talk about they have sleeping disorders, or they have coagulative issues, or they're having kidney problems, or they're having pulmonary problems, exercise intolerance, and all this stuff, right? But no one really was saying, what about the synergistic effects of all these manifestations and the importance of the primary care physician to tracking this, screening for it. Patient have had COVID, the patient should still be on the lookout that maybe long COVID will manifest itself in some way. You get COVID, you had, it was let's say a moderate case, not a mild case, but a moderate case or a severe case. So a severe case, you're in the hospital. You heal, you're fine. You don't have any exercise tolerance or anything. And then let's say 5 years later, you start seeing pulmonary fibrosis. All right. This is the reason why it's so important that as we're going into the post era of COVID, so post-COVID, that we have systems in place at the primary care level to be able to screen for long COVID, is my point here, and to catch it early. Because if you don't catch it early, then it will get worse. So thank you for listening. Thank you for supporting my channel. Hopefully you enjoyed this video. I'm giving it to the Patreon subscribers first, so they can digest this, and then I will share it to the public at large at a later date. Please subscribe to my channels, all 3 channels on YouTube, Brighteon, Bitchute, and Rumble. Please subscribe to my Twitter and GETTR social media and my Facebook. All the links are in the description. Please go to my store, the-studio-reykjavik.com, and please buy my health products. I have many health products that are related to nano silver, C60, boomer products, and rainbow herbals for deodorants. So please go to the store and get those deodorants. It's peppermint and tea tree as one scent, and the other scent is citrus. For good cardiovascular health, please go to my store and get the omega-3 supplement, boomer product supplement, on my store, the-studio-reykjavik.com, and this will improve your cardiovascular health. If you want to take a strong antioxidant and reduce that aging process and boost up your ATP and have healthier mitochondria, take C60. I offer it in 4 ounce and 8 ounce. You can get it in 2 different types of oil. One is avocado and the other oil is coconut. The MCT coconut has been found to be antiviral. But C60 is a very, very, very strong antioxidant. And I prefer the avocado. Some people prefer the coconut. But either way, it's a great way to bring down that reactive oxygen species and slow down aging. And please go to my store and get the nano gel. The nano gel is great in terms of having a lesion on your skin, putting the nano gel on and having it heal quicker. It neutralizes pathogens. It helps the skin heal quicker. And not only that, if you put this on your face at night and wake up and just exfoliate in the morning, you'll find that your skin will be more rejuvenated. Your skin will look healthier and younger after about 7 days, and your skin will be tighter. So just try that. This alone here is a great anti-aging product. So thank you for listening. I've done a lot for the audience in trying to move the ball forward in understanding COVID in all of its facets and giving you a solution to improve your health. Thank you for supporting the channel. Thank you for supporting my work, and have a nice night.